So thank you so much, Arup, for inviting me to talk on the 7 tips for toric intraocular lenses. Just give me a moment. I would like to make this a little more comfortable. Okay. So I am Ramesh Dorairajan from Sundar Eye Clinic in Chennai. So the first tip is to get an accurate K, and we should take the keratometry before applying any drops on the cornea. In my hospital, we do not charge for optical biometry, and the optometrist will take the measurements in patients with cataracts before dilating them. If they miss this step, the patient is called back for K on a different day. So a pristine K on a virgin cornea is most important. Just give me a moment. I have 2 presentations, and this is one of my prelim ones which has come up. I will, yes, here we are. So the second tip is, please, when you take a printout from your biometric meter, take out the toric printout. Don't take out the standard spherical equivalent printout. In addition, train your staff to check Barrett's online calculator so that if a patient asks you, doctor, which lens will you advise for my eye? It will be very easy to see. For example, in this particular patient, we know the spherical equivalent is going to be 23.5, but there's also a +1 cylinder, and a T2 will help this patient to some extent. So you can probably tell them that you'll have a little bit more clarity if you choose the toric lens package. The third tip is, don't use company calculators. Always use the Barrett's online calculator. There'll always be a small difference, whether it's J&J, Alcon, or any of the companies. For example, in this, the company calculator for this patient says axis of placement is 17 degrees, while Barrett's online will give you a 13. And this company says that you have to put a 2.25 cylinder in this patient, while here the Barrett online suggests that you put a three cylinder toric lens. So by and large, my results with the Barrett's have been extraordinarily good. So I don't go by the company calculators. I use only the Barrett's online calculator. This was beautifully explained by Dr. Harbans that you so often will get these 2 options. One will slightly give you an against the rule, and one will slightly give you a with the rule. I totally agree with this concepts that especially with the younger person where is likely to get more ATR cylinder as they age, it's better to go for a little higher power. And for the elderly people, you can probably choose a slightly ATR cylinder. Although slightly more against the rule residual astigmatism will give the patient better near vision, if you are planning to do a multifocal lens, or if you're planning to do a monovision for these patients, getting as close to plano excellent distant vision is most important. And so we should try to minimize the residual cylinder as much as possible. Barrett's online calculator will take care of variations which happen because of the anterior chamber depth as well as a axial length. So it does the internal calculation for myopes and the hyperopes. So probably we don't have to take that into consideration if you're using the Barrett's online calculator. But it's very important that you take into consideration the patient's pre-existing, whether it's with the rule or against the rule, and how old the patient is. Tip 3 is how to determine the axis in unusual eyes. So you take your topography for irregular cornea when you have a normal corneal thickness. Like in this particular patient who's got a corneal scar, there is no loss of corneal volume and the corneal thickness is normal. And anterior K, which you can get from topography, is enough. How exactly do you get the topographic K? This was described as a credit card method. You see the topographic map, and then you put your visiting card or your credit card so that it bisects the red as evenly as possible into 2 halves, and that will lead you on to the axis which this particular patient needs. On the other hand, when the corneal surface is altered due to refractive surgery, or if it's thin due to ectasia, the normal Gulston ratio is altered. In these patients, the posterior corneal measurement becomes much more important, and you must use an instrument which will give you a true K. A true K is a K reading where the calculation is taken based on both the front as well as the back surface. All the tomographers will do this for you. Most of the OCT based biometers also will give you a true K, and you must use the Barrett's true K formula as opposed to Barrett's regular toric where the anterior surface is taken into account. Now, these are the surgical tips for the first five patients, especially for the beginners. Please consider doing only ATR cylinders. These are more easy to do, and you will end up keeping the lens in the horizontal plane, not in the vertical plane. Your chances of rotation are much less in the horizontal plane. The lens will be more stable, and the calculation also is more easy. Please choose patients who need a higher correction for the initial patients. Don't take patients who need a one cylinder or a 1.25 or a 0.75 kind of correction. Though I have no financial interest, I find that Alcon toric lenses are the most stable of the several that I have tried. And so for your first 5 patients, make it easy on yourself. Please try an Alcon toric lens. And this is the one more tip. Use an SIA of 0. Understanding SIA is a key for improving your toric outcomes. And we should realize that less than 2.8 or even 3 millimeter temporal corneal phacoincisions induce negligible astigmatism, and they do not flatten the incision axis by 0.5 diopter. So we are not talking about the mean cylinder, we are talking about a centroid value. After seeing nearly 37,000 data from 37,000 eyes from various surgeons in different parts of the world, Warren Hill says that the average centroid value of the various surgeons seems to be around 0.12. So don't put 0.5 or 0.3 as your SIA. Choose a 0.12, or you can even aim for a 0. So what are the factors that affect the surgically induced astigmatism? Location is very important. If you choose a temporal location, you will have the least amount of SIA. Superior and oblique locations will give you differing amounts of SIA. Incision architecture, a single plane incision will give you the least. And if you have a small cornea, if you have a thin cornea, and you are operating on a young patient, very young patient where the cornea is less rigid, the SIA is likely to be higher. If you stuff the foldable lens through a very tight incision, you will cause incision stretching and tear of the margins, and this is likely to increase your SIA. So these are some of the factors that affect the SIA in any particular patient. Now, in all toric calculators, the mean value is not used, but the centroid value is used. Let us see how the centroid value is calculated. And this is from a series of 147 eyes. The next 5 slides are from Dr. Warren Hill's presentation. I thank him for giving me permission to use his slides several years ago. So these 147 eyes were had surgery by the same expert surgeon. Femtolaser assisted cataract surgery was done, and this is the sequential SIA of those eyes. And look at this interesting thing. See all the orange boxes, 0.13, 0.10, 0.04. Many eyes have negligible amount of SIA. But if you look at the pink, 1.02, 1.42. So, and look at this particular data. This patient has an SIA of 0.10. The very next patient by the same surgeon, same temporal flax incision, 1.42. So what this tells us is, in an individual patient, we have no idea what the SIA is going to be. SIA can vary a lot from patient to patient. So although we do a nice surgery, we have made an incision, we have aligned the intraocular lens, and we feel we are perfect, it is not logical if I imagine that I have flattened this particular incision by 0.5 diopter. If I imagine that, it is not true. This patient may have a very minimal astigmatism on some other SIA on some other axis, or he can have a much larger SIA on a totally different axis. I don't know what this particular patient's SIA will be. So in this series of 147 patients who had femtocataract done, the centroid value represents the most accurate value, and in this particular series, it comes to 0.08. So although you have different amounts of SIA, they are not all in the same axis. You see this point. 0.75 SIA at 45 degrees, and down here 0.75, this represents 0.75 cylinder at 120 degrees, here at 150 degrees. Because they're at different axes, they tend to cancel each other, and your final centroid value is a very small number, close to 0.1 in this particular series. So mean value is not important. Centroid value is how the calculators work, and in a nearly 32,000 cases, Dr. Warren Hill says the average centroid value for the average phacosurgeon is around 0.12. Now, as Dr. Husbands said, if your intraocular lens is a few degrees off target, he showed a beautiful curve. That is a remarkably interesting fact which never struck me till now. I learned so much from from the previous wonderful talk. But if your IOL is off by a few degrees, the effective correction will decrease. We know this. It's interesting that the effect of the toric lens will reduce if the rotation is clockwise or anti-clockwise. So it's impossible to overcorrect with the toric lens and possible to undercorrect. So I always aim for a little bit of overcorrection, and I keep my SIA not at 0.1, but at 0. So I'm betting that my lenses will be slightly off, and I'm compensating for that. Now here are a few surgical tips. Please learn to use the same temporal peripheral corneal incision. Cutting on the steep axis will not give you consistent result. Consider doing a posterior capsulorhexis and posterior optic capture if you have a very large bag and the lens is loose. If you're putting a plate haptic lens in the eye, especially in hyperopic eyes, and you try to rotate a plate haptic lens, it's possible to tear the zonules because these lenses can get locked in. So if you're using a plate haptic toric lens, please rotate it outside the bag to the final axis and tap it down into the bag. I do a single step slit lamp 21 gauge disposable needle marking. So we just before the operation theater, I have a slit lamp, and this has a slit where we can turn the axis to the final axis. The patient is seated, paracaine is applied, and we chat with him. Mostly he doesn't know what's happening. We do 1 or 2 parallel marks on the cornea. That's it. So I don't do 2-step marking, a reference and a final mark. I do a single needle mark, and this has helped me well for the last 10 years. And it's easy to get results like this: T2 lens, 6/6 partial post-op, etc., etc. Tip number 6, please be prepared to rotate or exchange the lens if needed. You can see this particular lens, this particular patient who had, he was in his mid-80s with, and he developed zonular dialysis during phacoemulsification. So I'm putting a CONE lens in, a CTR inside, and I'm anchoring the CTR with a Hoffman suture, and then I'm placing the lens in the eye. So when you're doing toric lenses, please be prepared for additional steps because every patient may not have a nice young patient with a very clear bag. When you want to rotate or exchange the lens, I don't have the brilliant mind of my previous speaker. I take the easy way out. So I use the Barrett's RX calculator or the Berthel and Hart and Toric IOL calculator. I've used this only once and my results have been good. And they do all the back-end calculation and just give me the final step to which I had to place the lens. So this particular patient had I had to place a suture because he had a small wound tear. And 2 months later, he was unhappy with a 1.25 residual cylinder. So I had to rotate this lens by 167 degrees as per the Berthel and Harden online calculator. And I'm using visco to separate the anterior and posterior leaflet. When you separate them, please start at the optic haptic junction where the addition is weakest. And when you inject visco, you can actually see the wave coming forward. This was done about 2.5 months after surgery, so it had fused quite a bit. So be prepared to rotate the lens or exchange the lens once in a while. Tip number 7, undersell and enjoy the wow effect. I tell my patients that they will see 5 to 10% better with the toric lens. There is very little pressure on them to choose this if they have financial constraint. And I tell them they'll be having the same clarity with a minor glass power and they choose a less expensive option. So it's up to the patient to choose a toric lens, undersell it, and many of them will come back and tell you, doctor, I never seen so clearly in my life. Even when I was young, especially if you correct a 3-cylinder or a 3.5-cylinder patient, they'll come and tell you they've never seen so clearly in their life, even when they were young. So this is my last tip for the day. Arup, over to you.